We have another case, another patient who has some complaints in the neck. The complaint is pain in this area of the neck. And what else?
What?
And in the back? Where in the back? In this area. She complains of pain there and in the back. Now, visual scanning to see what muscles are weak in the clear. Please move your head to the left. Head. This way. Okay, do it. Now to the right. We can see to the right we have a limited range of motion. Up, down. Flexion and extension are not so bad. Just the right rotation is limited. Lateral side, again, lateral. Back, again, back. If we see how she moves her neck to the lateral side, we can see that it's not normal. This is not the classical soft movement. She needs to move first the upper part of the neck and then bend the rest of the neck. This is the movement. Normally, the patient needs to move soft. In this case, is in 2 steps. Okay, do it. In both sides.
Pain.
Yes, and pain. Now, we are going to test some muscle to know where is the problem. If I test the posterior left extensor, I can see that this is weak in the clear. Very, very weak. If I test the right side, this is strong. But if I try to inhibit the muscle, how strong? Inhibits means this muscle is working well because it's strong in the clear and inhibit after local inhibition, autogenic inhibition. If I bend the neck, put in this position, now this is weak, this position, and this is weak. Yep. I'm going to see if this is scalene muscles or this is a deep muscles. I'm going to ask her to keep a slight lordosis and bend. There. Hold, and this is weak. Scalene muscles are weak in the clear. Now, straight, slight rotation, and push, and they are weak too. Yep. We have many weak muscles. Only the extensor in the right side is strong. But often become under hypertonic or contraction because it has no antagonist strong. If I ask her to do it again and test, I cannot see abnormal movement. If I test here, immediately I can see how she tried to compensate. Immediately I can see the tension, the contraction of the muscle around the clavicle. If she touch right clavicle, becomes strong immediately. If he touches the left clavicle, it's still weak. There. It's still weak. Again, touching the right side, I'm going to test the scalene muscles. Strong scalene muscle with a slight lordosis, and this is strong. Everything becomes normal with the hand touching this area. Now, my next question is this nociceptor? Is this mechanoreceptor? It's easy to test. Put the head there. I'm going to rub the clavicle and test. Is it strong? Move the neck, test again. I'm going to compress and test, and this is weak. It means that this is not a nociceptor. This is a mechanoreceptor. Now, how can I know what kind of receptor is? Easy, because I'm going to ask her to compress any tendon, hold strong, is strong, and I'm going to rub first, no, hold strong, strong, nothing happens. If I create a vibration, hold, it's strong. If I stretch the ligament between the clavicle and the sternum, immediately inhibits. Compress, release, still inhibits, is Golgi. I don't need any more. Here the compression of the tendon. And one stimulus, keep it strong. Double stimulus inhibits. It means this is the primary. And is the primary priority, is the most important problem for this dysfunction. Now, what is the opposite? If I compress twice, inhibits, because it's primary. Twice, 1 second, and compress again, it's still weak. Twice, and compress again, and keep compression, now, keep strong. It means that this is a Golgi, like main problem, main primary dysfunction, but the associated or the compensatory dysfunction is going to be a Pacini, deep pressure. To know where is the deep pressure, I'm going to ask her just to touch, don't compress, just to touch. Is strong, and I'm going to rub different areas to decrease the signal of the compensatory receptor that will increase the dysfunction of the primary. And when I rub here, inhibits immediately. It means that this is a Pacini. I'm going to stretch first this one, the tendon reflex, to create a very simple dysfunction, only one primary and only one secondary. And again, I'm going to rub the same place and inhibit again. This is the main secondary, the main compensatory. To treat the dysfunction, it's simple. Just stretch the Golgi and compress the Pacini and the tendon reflex. Now, I fix both dysfunctional receptors. If I test here, I compress twice, and now nothing happens. Keeps strong. And the neck is strong here, very, very strong. Skeletal muscles are very, very strong, and the other side is strong. Move your neck to me. Rotate the head. Now it's smooth, simple, and fast movement. This is P-DTR, is so fast. Thank you.